So hello everyone, this is Dr. Aminist again. Let us discuss about the Alzheimer's disease. Okay, currently 50 million people worldwide have dementia, with that Alzheimer's being the most common ones. Okay, 5 crore people, and Alzheimer's is the most common cause of it. That it accounts for 60 to 70% cases. Okay, now what are the clinical manifestations of Alzheimer's? Initial symptoms, most commonly it is memory impairment, but 20% of patients initially report like difficulty in word finding or organization and navigation and all. So most common is memory impairment. Now there are some other variants of the Alzheimer's disease also that we'll study. Most commonly there are four. First one is posterior cortical atrophy syndrome, okay, in which there will be visual processing dysfunction. Next is logopenic aphasia, in which there will be problem in naming and repetition difficulties. Corticobasal syndrome like Parkinson's, akinesis, rigidity, dystonia and all. Frontal variant will have dysexecutive and behavioral changes. Okay, now based on the which stage, early stage, middle stage, late stage or end stage. Early stage symptoms will be memory loss, subjective cognitive decline. The patient himself will feel that his cognition is been worsening. Okay, mild cognitive impairment will be there, noticeably memory loss. Okay, but confirmed on standard test. Okay, then preclinical Alzheimer's disease, in which there are biomarker evidence of amyloid pathology with or without symptoms, potential detected 20 years before the clinical symptoms. Okay, we can detect by PET scan or like amyloid depositions. Then seizures, partial or generalized seizures can precede dementia onset, especially in the younger patient or those with autosomal dominant mutations. Okay, next is middle stage symptoms, in which the daily activity interference will be there, like in the job or in the house or shopping, driving, etc. Language impairment will start, in that naming is gone, comprehension and fluency. Apraxia, apraxia like trouble performing the learned sequential motor tasks, like daily task of driving or working on some gadgets and all. Then visio spatial defects, so like dressing, eating, walking, etc., puzzle solving, geometrical figure copying, etc., is hampered. Then simple calculations, difficult with calculations and clock reading also will start in middle stage syndrome. Late stage syndrome is like ambulation. Patient will wander aimlessly. Judgment and reasoning is lost. There is a delusion with themes of theft, infidelity, or misidentification. Okay, behavioral changes will be there in this disinhibition, belligerence, passivity, and withdrawal. Sleep well disruption will happen. Nighttime wandering patient will do. Gait and rigidity will happen. Shuffling gait, muscle rigidity, Parkinsonian features without typical tremors and all will see. In end stage, guys, there will be severe impairment, rigidity, mutism, incontinent, bedridden, which requires assistance with basic activities. Then reflexes and jerks, it will be hyperactive tendon reflexes we'll see with myoclonic jerks. Now, what are the common causes at this stage in the Alzheimer cases? Malnutrition, secondary infections, pulmonary embolism, heart failure, and aspiration. So disease course, usually the average disease course will be like 8 to 10 years, ranging from 1 to 25 years. Okay, some patient will decline steadily, some patient will explain prolonged plateaus and all. Now, how to diagnose the case of Alzheimer's disease? Neuroimaging, in that early CT or MRI will be normal, but progressive disease will see that there is a posterior predominant cortical atrophy or medial temporal atrophy. What is the main purpose of doing this neuroimaging, guys? To rule out the other causes of like dementia. No, one is neurodegenerative dementia, in which the Alzheimer's is there. Other than that, organic causes like neoplasm, vascular dementia, diffuse white matter disease, normal pressure hydrocephalus, we have to rule out first. Then next is FTG PET scan. PET scan, what it will reveal? Hypometabolism in posterior temporal parietal cortex. Okay, next is amyloid PET imaging. Okay, redo tracers will be used different PIB, fluor beta peer, fluor beta ban, all these things we can use, and confirms the presence of neuritic and diffuse A beta plaques. Okay, it is positive in 25% of cognitively unimpaired older individuals. They are potential preclinical Alzheimer's disease. Negative scan makes Alzheimer's unlikely. Okay. Next one is tau PET imaging. Okay, radio tracers are 18 fluoroscopy and all these things. Pattern consistent with Bragg neuropathological staging will be there. Next is CSF biomarkers, and then we have to go for normal routine examination like CBCRF to rule out other causes. Abnormal markers, what we find out is A beta 42 levels and the ratio A beta 42 by A beta 40 ratio. It is reduced and it correlates with the amyloid deposition. Next is phosphorylated tau. It is increased correlates with tangle inclusions. Next is total tau levels. Non-specific increase will be there seen in Alzheimer's disease and other neurodegenerative diseases also it is present. Plasma measurements, what we will do with ultra-sensitive immunoassays or mass spectrometry. It shows a promise for increased access and affordability. Okay. Next is EEG. Non-specific slowing can be there or it can be normal also. But if you do extended EEG, it can detect the intermittent non-convulsive seizures also. Clinical diagnosis like typical presentation, which is slowly progressive decline in memory and orientation. In imaging, what we will see distributed or posterior predominant cortical or hippocampal atrophy you will see on MRI or CT. Confirmation is done by clinical diagnosis confirmed at autopsy 70 to 90% of the time. So what are the differential diagnoses of Alzheimer's disease? Like other causes of dementia we can consider. So if there is a prominent gait disturbances with memory loss, then we have to think of vascular dementia or NPH, that is normal pressure hydrocephalus. Next is if the Parkinsonian features are there with memory loss like tremors, bradykinesia, mask facies, then you have to think of Parkinson's disease or dementia with Lewy body dementia. Chronic alcoholism the patient is having, then you have to suspect with vitamin deficiency, guys. Like thiamine deficiency will present also like dementia. Loss of position and vibration sensibility is there, then B12 deficiency you have to think of. Okay, focal seizures if are present, neoplasm we have to suspect. Depression patient has in the history, then you have to think of depression related cognitive impairment. Next is history of psychiatric treatment, then you have to see the chronic drug intoxication because of antipsychotics. Rapid progression with rigidity and myoclonus, that is Creutzfeldt-Jakob syndrome, rigidity and myoclonus. Prominent behavioral changes and anterior predominant atrophy, then it is suggestive of frontotemporal dementia. The behavioral changes are prominent if you think him, then you have to go for FTD. Positive family history. Okay, so familial forms of Alzheimer's disease or genetic disorders can be there. Other than that, Alzheimer's you can have frontotemporal dementia, Huntington's, Prions disease, and hereditary ataxia also. Now, what is the pathology of Alzheimer's disease? Location of degeneration, where there is a damage in the brain. It begins in the middle temporal lobe, that is entorhinal or perirhinal cortex or hippocampus. Then inferolateral temporal cortex is involved, and the nucleus basalis of Maynard, where there is a deficiency of acetylcholine. Key lesions. What are the two key lesions? One is plaques and second is tangles. Neuritic plaques, which contains A beta peptides, proteoglycans, ApoE, alpha anti-chymotrypsin, which is surrounded by dystrophic tau immunoreactive neurites and activated microglia. The tangles, neurofibrillary tangles, which are composed mainly by phosphorylated tau protein, appearing as paired helical filaments by electron microscope. So we'll study about amyloid beta pathogenesis. So origin derived from the amyloid precursor protein, APP, amyloid precursor protein, through proteolytic cleavage by beta and gamma secretases. What is the normal role of this? Normal function remains uncertain, implicated in cellular dysfunction, okay, and toxicity when in soluble oligomeric forms. Plaque formation, A beta polymerization and fibril formation leads to neuritic plaques, a hallmark of Alzheimer's disease pathology. Next is amyloid angiopathy will also happen because of accumulation of this A beta in cerebral arterioles. Next is tau protein pathology. We'll see function. What is like normally tau protein stabilizes the microtubules, supports the axonal transport. Okay, but pathology, what happens here is hyperphosphorylated tau dissociates from the microtubules, and those phosphorylated tau proteins aggregates in the neurofibrillary tangles, compromises neuronal functions. So it spreads like a prion-like templating process, may contribute to like tau spreading and pathology progression. Comorbid pathologies, common associations with it is Lewy body dementia can be there, or TDP43, that is TAR DNA binding protein 43, or vascular pathology can be there. In rodent models, typically involve mutant transitions leaded to A beta 42 accumulation, reducing neuronal tau, and can ameliorate cognitive defects despite ongoing A beta 42 accumulation is seen. Now, biochemical changes. Main is neurotransmitter depletion. Neurotransmitters like acetylcholine, choline acetyltransferase, nicotinic cholinergic receptors due to degeneration of cholinergic neurons in nucleus basalis of Maynard. Next is neuroadrenergic and serotonergic depletion. Why? There is a degeneration of brainstem nuclei like locus ceruleus and dorsal raphe, that's for serotonin. Okay. Next is, now we'll see about the treatment. Treatment main is like patient and care, because it's a chronic disease which progresses slowly. So we have to build a nice patient caregiver system for the patient. In that, what it includes, building the rapport. Okay, we have to establish the trust and understanding the patient. Memory aids like notebooks or reminders like that, we have to help the patient with. Environmental safety, as the patient will be wandering, he will be, orientation will be lost, so ensure home safety and remove the hazards. Driving, patient should not be allowed initially. And stress management. Okay, communication with the patient, clear repeated reassurance is crucial for the patient for avoiding the depression like symptoms. Caregiver support. Okay, now next is neurotransmitter based therapies, that is pharmacotherapy. Main what we use in the initial, when you start the treatment, is with cholinesterase inhibitors like donepezil, rivastigmine, and galantamine. Okay, what is the mechanism? It inhibits the acetylcholinesterase, as all we know, increasing the cerebral acetylcholine levels. You have to start with low doses, escalate gradually over 1 to 1.5 months. Okay, to minimize the side effects. What are the side effects? Like bradycardia, altered sleep, muscle cramps, gastrointestinal symptoms, and all. Efficacy, the modestly improve caregiver ratings and slow cognitive decline over 1 to 3 years. Okay, next is NMDA receptor antagonist like memantine. So this mechanism is by it blocks the overexcited NMDA glutamate receptors. Okay, it is approved for moderate to severe Alzheimer's disease. It slows the cognitive deterioration, reduces caregiver burden. Side effects are constipation, dizziness, headache, and somnolence. So, combination therapy, we have to start with cholinesterase inhibitor for mild Alzheimer's, add memantine in moderate disease stages. Symptoms management, like cholinesterase inhibitors can help with delusions, okay, hallucinations, and memantine on the other hand, it will reduce the agitations as it is blocking the NMDA receptors. Okay, now what are the newer therapies in the Alzheimer's will study? Aducanumab. Okay, what is the mechanism? It inhibits the alpha beta, sorry, A beta peptides, N terminus of A beta peptides. FDA has already approved it, and in clinical trials it showed that only at the higher dose, okay, it showed the benefit. So higher doses like 10 mg, it starts from 1 to 10 mg. 10 mg they showed in the trial that it is effective. So what is the patient selection for this therapy, aducanumab? Mild cognitive impairment or early dementia due to Alzheimer's. These are the selection criteria, and it should be biomarker confirmed by CSF or PET scan. A beta pathology has to be confirmed. If there is other causes of dementia and we are treating it, there is no use. We are risking with the side effects. Exclusion criteria, we cannot give if there is a prior brain hemorrhage, active anticoagulant therapy, unstable medical conditions like CLD, CKD. You cannot use aducanumab. How to administer? You have to give it in IV infusion over every 4 weeks, titrated from 1 mg to 10 mg over 7 infusions. Okay, safety monitor. There are the two significant side effects, that is amyloid related imaging abnormalities we call, and the types are, one is vasogenic edema, that is amyloid related imaging abnormality edema, and cortical microhemorrhages, that is ARIA H hemorrhage. Okay, most cases occur within the first 8 infusions but can happen at any time. Symptoms mild to moderate like headache, altered mental sense status, dizziness, visual disturbances, nausea. Severe cases will also present with focal neurological deficits. Special consideration, MRI contradiction. If the patient cannot undergo MRI, then it is not suitable for the aducanumab therapy. ApoE genotype considered to assess risk, as the edema is most common in ApoE. What are the additional therapies? For the depression, you use SSRIs like escitalopram 5 to 10 mg daily. For seizures, you use levetiracetam. For neuropsychiatric symptoms like agitation, insomnia, hallucination, belligerence, for that you can use atypical antipsychotics like risperidone, quetiapine, olanzapine, etc. Side effects, as you know, gait issues, sleep disturbances, cardiovascular, metabolic syndromes, and all. Okay, behavioral management, for that you can, that is the non-pharmacological approach, but may always be available, effective or necessities medications for some patients. Okay, and avoidance of anticholinergic medications, vigilance needed to avoid medications with strong anticholinergic effects like diphenhydramine, oxybutynin. Other therapies which are still in trial, some are not recommended, some are still going on. We'll study about that, like estrogen hormone replacement therapy, statins, vitamin A, ginkgo biloba has not showed any promising results, but still their trials are going on. Next is vitamin and dietary supplement. They are called memory enhancing, okay, or protective against, but the support efficacy is not that evident. Controversial and unapproved therapies, like anecdotal reports, some patients or family, they might come to you and they'll say that please try this treatment because I've seen articles. So like that, anti-interferon intrathecal infusions, anti-interferons, IVIGs, antibiotics for Lyme disease or other infections, metal chelation, stem cell therapies, and all, etc. Now, what are the experimental recent advances going on is like PET and CSA biomarkers, which we already use in clinical practice, like essential for trial inclusion to assess target engagement and modification of disease pathology. So changes in A beta or tau is been done. Shift in trial focus, like increasing enrollment in asymptomatic or early symptomatic Alzheimer's disease stages using positive biomarkers are as primary criteria. Prevention trials conductive in autosomal dominant mutation carriers, ApoE, epsilon 4, homozygotes, and aging population to explore primary and secondary prevention strategies. So anti-A beta monoclonal antibodies, adagonoma we know, but beyond that, other are lecanemab, gantenerumab, donanemab. Okay, they show robust amyloid plaque reduction in PET and are clinical trials for clinical to mild dementia stages. But safety concern, they have a lot of side effects like vasogenic edema or microhemorrhages are significant. Active vaccination against A beta. So in they halted this trial because of side effect, that is meningoencephalitis, but they are the trials are ongoing with less immunogenic formulations. Next is beta and gamma secretase inhibitors, okay, which will convert the precursors to the A beta amyloids. So these trials have been ongoing, but they have seen that there is a transient worsening of cognition. Okay. Next is monoclonal antibodies against the phosphorylated tau. Okay, this is in the still development stage. Yeah, they have done it in the mice, but not in the humans yet. Has to be done. So other therapies like neuroinflammation, targeting the neuroinflammation, or synaptic plasticity, metabolism and bioenergetics, neuroprotection, okay, and neurotransmitter based treatment. All is all going on. Thank you.